Who are we? We are not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learnt what so many of us have forgotten. The value of every single day. The preciousness of every breath, of every heartbeat. We make tears, tears of thanks for the release from pain. And then there's hope. The hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Alison, Seb, Topeka, and Zunaid. And that is why we are not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life.
Hello, I'm Dr. Elna Rudolph, and I'm the president of the 25th Congress of the World Association for Sexual Health that will be hosted by SASHA, the Southern African Sexual Health Association, from the 9th to the 12th of September as a virtual event. I welcome all of our local and our international guests to this webinar series. Last year, when COVID hit, both organizations, WAS and SASHA, jumped at the opportunity to connect with our audiences and bring you world-class information. And if you've been following this series, I'm sure you will agree that we have all learned a lot. And tonight is, to me, the absolute highlight of both of these series. Join forces this year, mainly leaning on the amazing expertise of the team to do this webinar series as the run-up to the World Conference. And I personally want to thank every single member of SASHA for the hours and hours of work that they put in to make a world-class event like this happen. Thank you for your time, and thanks again to all of you for joining us. I would like to welcome FIGO with us tonight. That is the International Federation for Gynecology and Obstetrics. And their Vice President, Faysal El Kak, is joining us as a speaker, and welcome to all of you to our session. And then thank you to CIPLA, who is sponsoring tonight's event. You make it possible for us to keep on bringing high-class information and events to our audience. We appreciate it and share in the introduction. And then I would just like to introduce the whole panel tonight. I'd like to ask you to please switch on your cameras, and I just want you to say hi to our panel. First up, we've got the president of SASHA that I'll shortly introduce, Anthony Smith from South Africa. And then we have our other moderator, Woet Gianotten from the Netherlands. And we've got Jim Pfaus all the way from Mexico. You're in Mexico at the moment, I think, Jim, or and Catriona Boffard is from South Africa, and then we've got Faysal El Kak from Lebanon. Thank you so much to all of you for making it tonight, and I am so looking forward to this event. I can tell you, if I had the opportunity, you know, if they say you can invite any 6 people to dinner, it would be you guys, and we'll sit around a table and we will talk about, we'll never even reach politics and religion, we'll talk about sex the whole night. So this is basically like my private little dinner party with my friends tonight. I am so thankful that all of you have taken the time to be here, and I can't wait to hear what you have to say. So I would like to introduce Anthony to you. Anthony is the person that really needs the most special mention here tonight, because, you know, I see Anthony working in the middle of the night, like in midnight, because during the day, he is actually saving real lives. You know, the rest of us are just saving sex lives, but Anthony is saving real lives during the day. And then in the evenings, he has pulled together all of these series, and he's been taking care of the conference that's about to happen and all of the other day-to-day stuff at SASHA. So Anthony, I really thank you from the bottom of my heart for all of the hard work that you are doing for SASHA. You are really doing us proud, and it is my absolute honor to introduce you to this international community tonight. Dr. Anthony Smith is a family physician and a medical sexologist. He holds a master's degree in family medicine from the University of Cape Town and a master's in medical anthropology from the University College of London, and teaches in the Department of Family Medicine at the University of Cape Town. He is a fellow of the European Committee of Sexual Medicine and serves as the current president of SASHA. He is involved with both clinical and educational aspects of sexual medicine at undergraduate and postgraduate level, is on the subcommittee currently formulating the higher diploma in sexual medicine and HIV for the College of Family Physicians, and is part of the Sexual Health Editorial Board for the African Bureau of Primary Healthcare and Family Medicine. Anthony, I remember when I asked you to please stand for the president of SASHA, you thought that you were not duly qualified, but anybody listening to that CV can confirm that you are absolutely qualified to be in that role, and you are doing it so well. And then next up is Prof Woet Gianotten. You know, when I said hi to him in the introduction and thank you for joining us tonight, I actually shed a tear, because Woet, I look up to you. I respect you so much, and I thank you for looking at me that day in Singapore and basically telling me that the next conference has to come to Africa. And thank you for taking an interest in me and my career. You wouldn't know how much it has meant to me over the years. So, Woet is a medical doctor and psychotherapist and an emeritus senior lecturer in medical sexology. After meandering through surgery, tropical medicine, gynecology, contraception, and common sexology, he finally ended up in complex medical sexology, where disease, cancer, old age, and medical interventions tend to undermine sexual functioning and sexual pleasure. His current professional life consists mainly of teaching healthcare providers. And like for Jim Pfaus, I have flown all over the world to hear you speak. So people will hear how you speak on this topic now, and I look forward for people who don't know you well to be introduced to that, because you have such a gentleness to the way that you share this passion. And I know you're passionate about Africa. You've worked here for years, and thank you so much for joining us tonight. I hand it over to you.
So first, I will give a very short introduction to sexual desire from my very clinical perspective. And then I will hand over to the first real presentation by Jim Pfaus. I want to tell you about 3 different patients. The first one was Andrea. She was sent to me by her endocrinologist. She was 22 years of age. She was a primary school teacher. And the endocrinologist, he was worried about her sexual development. And the reason was, at age 7, she got a tumor in her brain, a pituitary tumor. And that was surgically removed. And then she had, of course, no more the proper hormones and no more proper hormonal feedback loops. So she got hormonal substitution. And when she was at age 12, she got estrogen and progesterone. So she got her normal menstrual periods and normal development. When I took a sexual history, that was, as I nearly never had seen, absolutely empty. She had no sexual desire at all. She had never any sexual fantasy. She had never fallen in love. She had never masturbated. And then it is rather clear that's because she had no testosterone. That was already clear from the history, and that was found as well in the laboratory. So we gave testosterone substitution to Andrea. And the funny thing was, 6 weeks after, when she came back, she said, "Doctor, you know, there is a boy living in our street." She never had been aware of boys. When she was using the medication for about 10 weeks, she had discovered masturbation. And then I could send her back to her own endocrinologist. And at the final consult, she said, "Doctor, now I understand a lot of jokes. It seems that for jokes, you need as well an amount of testosterone." The second is Mr. B. He was a retired lawyer, and he came with his wife because his wife recommended him together to go to the sexologist. 2 years before, he got prostate cancer with bone metastasis. That means you can't treat it locally. So we treat it then by androgen deprivation. That's kind of chemical castration. And when you get it, you have no more testosterone, because testosterone helps the cancer cells to grow and to multiply. So we remove the testosterone. His sexual history before the treatment was that they both liked sex, and they had 2-3 times a week they had intercourse, but it was always him being the initiator. But since he got this treatment, all his desire completely disappeared. Now, the problem was in this case that his wife never learned how to take the initiative. So by now, he is not having desire. She doesn't take initiative. So you have 2 people standing out in the cold. So the treatment here was, of course, not by giving testosterone. That's not allowed. That's too dangerous for his cancer. No, they learned to renegotiate patterns of how to deal with each other and renegotiate intimacy. The third is Toby. Toby is still a young man, 29 years of age. He was married, and he was referred by the fertility department. because he came, she didn't get pregnant, and then they had a look at him as well. And they asked, please, can you look at his sexual behavior? He has a low sperm count, he has normal hormones and normal testosterone. And then in his history, he had intercourse 4 to 5 times a week, but it was always initiated by Anna, and he had ejaculation. And then I asked him, is that with satisfaction? And then he looked a little bit flabbergasted. I said, I don't know. And then I asked him, are you satisfied when you masturbate? No. And then it became clear that Toby masturbates about 5 to 6 times a day. And then you can ask sexual desire. And then he answered, sexual desire? No, not really. So a man who has 5 or 6 times a day sex, he had no sexual desire. And then to me, that was rather clear. There was something wrong with his upbringing, and he had been sexually abused for 3 years every week by his judo teacher. So you see here 3 different cases with 3 different causes and 3 different treatments. Now I look to another person, which is mankind, who lived about 130,000 years by now. Cindy Meston found 237 different arguments to have intercourse. And researchers and clinicians found more than 237 different arguments to have desire problems. So let's respect human diversity, because that creates the joy of working in our field. And that brings me to the next speaker. The next speaker is Professor Jim Pfaus. Jim received his PhD in behavioral neuroscience in 1990. After postdoctoral training in molecular biology and behavior at the Rockefeller University, he accepted a position as a visiting honorary senior researcher at the Centro de Investigaciones Cerebrales Universidad Veracruzana in Jalapa, Mexico. His research is concerned with the neurochemical and molecular events that subserve sexual behavior and neuroendocrine functions. His research in human sexual function is focused on subjective and objective measures of sexual desire and pleasure in women and men, using a combination of eye tracking, EEG, brain imaging, and genital arousal measures. Jim has published over 200 research papers, reviews, and book chapters with his students in peer-reviewed journals and books, and is sought after to present his research at numerous scientific conferences and consultations worldwide. He's the editor-in-chief of Current Sexual Health Reports and associate editor of the Journal of Sexual Medicine and Sexual Medicine Reviews. And he's on the editorial boards of Behavioral Neuroscience, Physiology and Behavior, and Investigative and Clinical Urology. Jim, you've got the floor.
Thank you very much, Woet. So I'm going to be talking today about brain mechanisms of sexual desire. Here are my disclosures, grants and contracts, SAD boards, and honoraria. And if we could put up the first 2 poll questions, that would, yeah, great. So I'd like you to consider these 2 poll questions in the next 30 seconds to 60 seconds, and just see what you think about it before the talk. Okay. So as you do this, I'm gonna go on. So we can remove this from. Do I remove this? Yeah. Okay. So I'm gonna go on. And since you put up the poll question, there we go. So Masters and Johnson proposed a 4-stage sexual response cycle model. Really, they stole it after Albert Moll from a book in 1908. But in this model, there were 4 stages: excitement, plateau, orgasm, and resolution. And Helen Singer Kaplan in 1974 said, well, what do we mean by excitement? Is excitement just electricity, or is it really something that you can define objectively? She said that excitement was a mix of arousal, both genital arousal and increased activation of your heart, plus desire, something more cognitive. And you can see that Yannick Georgiadis has kind of framed this in a more general setting of wanting, liking, and learning. Okay? Well, some definitions. What do you mean by sexual arousal? I mentioned increased genital blood flow, but really you also have your own perception, or your brain's perception of increased heart rate, sweating, pupil dilation. What do we mean by desire and interest? Well, wanting or craving sexual activity and kind of focused attention or focused behaviors that are aimed at acquiring sex partners or sexual reward, whatever those rewards might be. Sexual reward comes in the form of pleasure, orgasm, intimacy, bonding, control. There are other rewards that are associated with having sex. And of course, leading then to the resolution, which is really refractoriness or sexual inhibition. We're talking about a state of satiety. But we can also be talking about a state of primary aversion, secondary avoidance, for example, in women that have dyspareunia, where these types of things are now going to be stopped before they start. Rosemary Besson took this idea a bit further, saying, well, it isn't just 4 things, there's a whole bunch of things that we respond to, and that the desire component really kind of has like a drive state and an incentive state. And we would think of the drive state as what Rosemary calls innate sexual desire, something that might be hormonally driven, as you saw in the examples that Woet described. Then there's responsive desire that is experientially driven. In both cases, you have increased receptiveness to sex, increased attention at sexual stimuli, increased awareness of your own sexual arousal, and all those things are going to conspire together to give you or to lead you to the sexual rewards that make sex what it is. In this EPOR model, we see that that these 4 stages at least are associated with different patterns of brain activation. Each stage is associated with particular activation of the brain, as you can see on the bottom here, moving from excitement to plateau to orgasm, and then to refractoriness. Orgasm in particular gives rise to refractoriness, which is inhibition. And notice big activation of prefrontal cortex, right? Which is, of course, part of your executive function, among which behavioral inhibition is a very important component. But what this does is really kind of suggest the existence of kind of 2 systems, an excitatory system for sex and an inhibitory system for sex, and ones that involve particular actions of neurochemicals. It fits in nicely with the notion of a dual control model, right? So you have inhibition and excitation kind of being like a seesaw, but around a sexual tipping point that is labile, that you can move into excitation when something exciting is there, physiologically, psychologically, culturally, and that you can move into inhibition when you shouldn't be doing what you want to be doing, or you're just not in the right place at the right time. So if you look on the right-hand side, sexual excitation involves the activation by drugs or states that activate excitation, excitatory neurochemical systems, or drugs or states that inhibit inhibition. We think of that as disinhibition, right? So if you inhibit the neurochemical systems that typically come online at orgasm or come online with stress, you could tilt yourself to excitation. Likewise, sexual inhibition involves the activation, either from drugs or states, brain states that activate those inhibitory neurochemical systems or that deactivate or inhibit excitation. Much the same way that in the normal cycle of sexual activity, orgasm leads to refractoriness, or to the resolution, we would call it. So if we think of the process of sex, how does sex work? You have hormones that are circulating levels in the body, actions in the brain that are activating arousability, activating attention, right? Just as the testosterone, which is one major hormonal component, will do. You're taking sensory input from the genitals, which is your perception of arousal, sensory input from incentives, olfactory, visual, auditory, whatever your preference is, that leads to net behavioral output. Your interest in having sex, solicitation of sex, your pursuit of a sex partner, and leading to active copulation. Notice on the right-hand side, you also have experience and expectation. And this is, the brain is an experience-dependent organ. It learns, and it learns what you like and what you don't like. So from previous sexual encounters, you're also going to activate arousability and attention. Right? And what's very important is that expectation can also change the way hormones get activated and change their cycling levels in the body and, of course, their actions in the brain. So what do we know about arousability and attention? Well, we know that norepinephrine and oxytocin are two neurochemicals that are very, very potently involved in arousability. And we know that dopamine and one of its neuropeptide drivers, the melanocortins, are very important for attention. So you mix these two things together, and now you have a brain that is very focused, a mind that is very focused on sex-related cues. At orgasm, we have the activation of opioids. It gives you the sort of the bolus of pleasure that we receive at orgasm, and also the activation of serotonin, which is very important for satiety. What do? They activate or they deactivate arousability, they deactivate attention, and that deactivates the net behavioral output. With hypoactive sexual desire disorder, or what the DSM calls female sexual arousal and interest disorder, these occur in women or men without concomitant, or without necessarily concomitant decreases in physiological or subjective arousal, or indeed hypogonadism. And the etiologies, if you think about it, come from two very important, but maybe even a mix of the two sources. One is hypofunctional excitation. So in response to sex cues, you are simply not aroused, as the first of Woet's patients. You have hyperfunctional inhibition. So this would be a situation where you are in a sexual circumstance, but you simply don't function sexually because, the paint's chipping on the ceiling and who's going to take the kids to soccer? What's happening that is not allowing you to focus, but is now inhibiting through some kind of an external attentional mechanism? There are approved treatments and potential treatments for HSDD, which gives us a glimpse into those neurochemical systems. There are experiential treatments, which I'm not going to go into because I think my comrades here will. There are hormonal and psychopharmacotherapeutic, like estradiol and testosterone. There are also two FDA-approved treatments. There's flibanserin, which is an anti-serotonergic called Addy, and bremelanotide, which is actually a pro-dopaminergic called Vyleesi. And then there are several others that are in the pipeline. Well, let's talk about neural excitatory systems. I'm going to talk mostly about dopamine and melanocortins and a little teeny weeny bit about oxytocin. But dopamine is classically important in all motivation. Why? Because the mesolimbic dopamine system that everybody talks about in terms of drug addiction is involved in sexual behavior, not necessarily sex addiction. I don't really think you become addicted. You can be OCD about sex, but addiction's another thing entirely. But that system is what basically provides you with motivation, energizes motivation, and energizes attention toward cues in the external world that you need to be aware of. And that system is in part driven by these hypothalamic systems, one of which in the medial preoptic area is very important, that controls endocrine autonomic regulation and desire. And then, of course, you have the nigrostriatal system that controls movement. The melanocortins and oxytocin, indeed, if you look at where they are in the brain, they overlap dramatically with dopamine systems. Well, major dopamine pathways, you can see on the right-hand side in pink, go from the ventral tegmental area in the brainstem up to limbic structures. That's the mesolimbic pathway. You see the medial preoptic area, incredibly important because this is a region that kind of controls both autonomic outflow and incoming incentive information, motivationally relevant information, and its outputs to the VTA are what kind of focus your attention on sex-related cues rather than food-related cues or your car or something else. In terms of dopamine, this zona inserted to preoptic area, which you see in red there, its output is controlling genital responses, appetitive behaviors, and somatomotor patterns. And you notice that then it combines with the mesolimbic and nigrostriatal system to really guide attention and behavior towards sex cues. Dopamine release in the medial preoptic area is a general neural switch that controls, switches you from sympathetic to parasympathetic and back again, blood flow in the presence of those sexual cues. So it's linking these things together. It's a very small region of the brain, you notice right here around the third ventricle. And you can see in both men and women, it's activated in response to visual erotica. These are non-clinical samples, because in clinical samples, you don't see it activated. Very interesting. Now, bremelanotide is a melanocortin agonist. It binds to melanocortin type 4 receptors in the brain. It induces erections in healthy men and healthy rats. Certainly, I studied the rats in my lab. It induces erections in men with mild to moderate erectile dysfunction and those that don't respond to the PDE5 inhibitors. It has a rapid effect in rats and in humans, but behaviorally, it facilitates solicitation selectively in female rats, which is a female rat way of showing desire. And it facilitates anticipatory locomotion in male rats, which is a male rat way of saying, oh boy, I'm going to have sex. Well, when you give the drug alone, see what saline does in the medial preoptic area, nothing. But you can see the activation of these little black dots. This is a protein called FOS. It's a way of getting cellular resolution in the brain to look at activational patterns. And notice the drug alone is activating the MPOA in a manner that's identical to the way the MPOA was activated by those erotic cues in humans. What that means is the drug alone is a priming cue. It's a pharmacological priming cue that now activates the system that now just turns up the gain on that excitation. In female rats, you can see it increased solicitations. It dose-dependently does so. But I call your attention to the blue in the lower left-hand corner, where you can see that MPOA dopamine was increased after bremelanotide treatment. And if you go over to the right-hand side, you can see that that increase in solicitations was reversed by a D1 dopamine type 1 receptor antagonist. So blocking that dopamine receptor, which bremelanotide doesn't bind to, blocked the dopamine's induction of solicitations. It was a D1, not a D2 effect. Why is that important? Because it told us where the mechanism of action was. It was at presynaptic dopamine terminals that are releasing dopamine into the medial preoptic area. When that dopamine is at, when you're at rest, unstimulated, there's always a little bit of turnover. But when that dopamine is activated, stimulated, not only by external cues, but by the drug itself, because it opens calcium channels and now releases more dopamine, now the gain is turned up. And why is that gain important? Because these D1 receptors are on neurons that are inhibitory, that go to the VTA and inhibit inhibitory interneurons. So the release from inhibition allows more dopamine to be activated in that mesolimbic system. So it's now combining, right, physiologically combining as a priming cue, your reaction to the external world and the activation of genital blood flow. In female humans, bremelanotide increased desire and it decreased distress. These two things with minor side effects are the reason why the FDA approved it. What else coordinates genital blood flow and sexual desire? Well, it's not just that dopamine, as you see in the middle here from the hypothalamus and medial preoptic area going to the VTA and activating desire, attention, but it's also oxytocin. That zona-inserted dopamine drives oxytocin release from the paraventricular nucleus into the VTA, which directly drives dopamine. And that produces an extra added layer of partner preference. But you can see the oxytocin is also activating at the spinal cord and at the genitals themselves, vaginal, clitoral, labial blood flow, penile blood flow, stimulation, because as you open up the glands, you open the glands up to stimulation. That's true for both the penis and the clitoris, and cervical stimulation, because they have oxytocin receptors on the cervix that drives cervical activation. So this is partly driving orgasm. What about neural inhibitory systems? Oh, there are opioids and serotonin. Serotonin is the biggie because people taking serotonin reuptake blockers, for example, what do they experience? Lack of orgasm. Well, the prefrontal cortex controls executive functions. And as I mentioned before, behavioral inhibition is a very important component of executive function. The inhibitory outflow from the cortex on down, that's part of behavioral inhibition, is regulated by serotonin and serotonin type 2 receptors, 2A in particular. And when that outflow is activated, it shuts the MPOA down. It shuts the amygdala down. It shuts down the ventral tegmental area, shutting down mesolimbic dopamine. So here you see the activation of serotonin on serotonin type 2 receptors, activates these excitatory glutamate outputs that activate another glutamate output that activate those inhibitory GABA interneurons in the VTA that inhibit dopamine. When you block serotonin, or you block the 5-HT2A receptor, that whole system doesn't come online. Well, that's part of the putative mechanism of flibanserin. Flibanserin, by being a 5-HT1A autoreceptor agonist, means it shuts down serotonin release. And by being a 2A receptor antagonist, it blocks those receptors. So you kind of got 2 feet on the brakes. And what does that do? Well, for women who, and men in particular, who have decreased sexual desire because of over-inhibition, overactivation of that kind of descending cortical system, you now increase sexual desire, you decrease sexual distress, and you have an increase in sexually satisfying events. We saw this in female rats. Now, you know, with flibanserin, you got to be on it every day before this actually kind of turns on sufficiently. And you can see that after 21 days, female rats begin to start showing solicitations. You can see here that it, using microdialysis to actually examine the neurochemistry, that it decreases medial prefrontal cortex serotonin, right? And in the nucleus accumbens and MPOA, it also decreases serotonin. Whereas go over to the other side, you see it increases dopamine in the prefrontal cortex and down below in the MPOA. It doesn't do it by itself in the nucleus accumbens because these animals are not exposed to a sexual related stimulus. But when they are, you get the increase. So you've disinhibited now. And here are the desire and distress scores from the human clinical trials of flibanserin. So again, desire goes up, distress goes down. That's exactly what you want. You don't want to turn that seesaw into the excited mode. You just want to turn it back to labile from inhibition. So that's how I'm going to end my talk. Again, I told you about sexual inhibition versus excitation. Well, inhibition, when you're locked in inhibition, either by decreased excitation or increased inhibition, it's hard to get out of that. You don't have an excitatory response to external cues that would normally excite you or did excite you in the past, or you are locked in an inhibitory state, which will decrease your desire. And in fact, if you're taking SSRIs, which of course are amplifying serotonin, you are now locked in a state where if you have desire, it's very hard to have an orgasm. Drugs or states that turn you the other way can actually now produce lability in this seesaw. So that activate dopamine in particular, but activate noradrenaline, oxytocin, or even melanocortin type 4 receptors to essentially activate dopamine, are now either going to directly activate excitation, or in the case of flibanserin, drugs or states that inhibit the serotonergic overactivation are going to now shunt you back to that state. So I'm going to end with this. These treatments for HSDD and FSAID either inhibit inhibition, so sensate focus, mindfulness, flibanserin itself. Testosterone with buspirone may in fact do this as well, right? Or you're going to facilitate excitation on the left-hand side through things like sensate focus, through bremelanotide. Testosterone, of course, does this as well, both directly at the level of the genitals, but also in the brain. There are other things in the pipeline here in kind of a brownish color. They're activating either one of these two systems. And I'm going to leave you with this thought. There is now a companion diagnostic using single nucleotide polymorphisms that can show you, in women at least, predisposition to increased inhibition or decreased excitation. So we may have ways to actually slate drug treatments and even talk therapy treatments better in a more personalized medicine way to women that have, or men for that matter, who have increased inhibition or decreased excitation. Thank you.
Okay. Thank you very much, Jim. This was a marvelous presentation, and I wished I could take you to the rehabilitation center where we have a lot of men and women with traumatic brain injury or stroke, who have all the different pieces of the brain are sometimes disturbed, sometimes with lower desire, sometimes with more desire, sometimes with inhibited things. It's fascinating to see this all, and I think that should be in some way connected together. We've got some questions already for you. One of the questions was on the role of oxytocin. Does a nasal spray increase or decrease the sexual desire in women?
Well, that's very interesting. In some cases and in some women, the sexual desire can be increased because their perception of arousal is increased. So I would, again, that could be because of decreased excitation overall, right? So oxytocin might do it, a noradrenergic agonist might do it. Again, bremelanotide does it as well. So oxytocin is playing a very similar role to dopamine in that regard. So, but there are not that many clinical trials that have been done on intranasal oxytocin. I think we need to have a really big, honest-to-God clinical trial. I don't know who's going to do this because oxytocin isn't owned by anyone. So the profits from this are not likely to be the same as the profits for a drug that would be proprietary.
I got another question. You mentioned that drugs like flubanserin and bremelanotide act as a pharmacological priming cues in the brain. Could you elaborate a little bit on that?
Yeah, I mean, it's kind of a new idea. We tend to think that drugs kind of take over the system, right? And that drugs make you do things that you might not normally do. Drugs actually simply, they can affect movement, of course, but what they do is they potentiate your attention to particular things in the environment. And that's partly driven by the state of your brain at the time you take those drugs, but it's also partly driven, I think, by like need states that you might be in. So it's not simply incentive, there's also a drive component to that. When I say that they act as priming cues, what I mean, it was really something for us to see bremelanotide activating the MPOA on its own. Because I know that sex cues activate the MPOA. So when a drug does that, what's it really doing? It's not making you do something. It's simply increasing your attention now to sex cues in the external world, as opposed to food cues or car-related cues, or the work that you have to do by tonight and get it done by a deadline. You're increasing awareness of a particular thing that's now being focused by the regulatory system of your brain. That's what I mean by a priming cue. I mean, when we do eye tracking, we give like visual priming cues. And a visual priming cue would be something that as you're walking on the street, you see someone who looks beautiful to you, and you like turn your attention around and you look at this person. I think that's an important component of what a prime does to the brain. Pavlov used to call these priming cues things that kind of drive cortical activation and focus attention. And I think, Pavlov once said, if you want new ideas, you should read old books. I think that's the idea of a prime. It's really focusing attention.
Okay, thank you very much. I think now we will give the floor to, first we see the poll results of what you said.
Very interesting. Very, very interesting. Thank you all. Thank you all for participating. Yeah, which is really cool. Well, it'd be interesting to see if people have changed their view. Thank you all for this.
Okay, good. Then we go now to Anthony.
Woet, thank you so much. And I just want to say for myself what a pleasure it is to be with you all tonight, and to help to be moderating what is already a really fascinating discussion. And Jim, thank you for really such an excellent talk, for which there's I think something to be chewed over on numerous exposures or watching of that talk. But I think to move on, it really gives me a great deal of pleasure to introduce a South African and international well-known sexologist, Catriona Boffard, who I have to say really remarkably combines a whole lot of different spheres into the work that she does. She's very much involved in clinical care. She's involved with research, and also has a remarkable podcast, which I would advise all of you to follow up on, where she engages both the public and important personalities in the world of sexual health. So really, I can't advise you enough to watch that. But more formally, if I may introduce her, as a clinical sexologist, a psychotherapist, and sexuality researcher, she's accredited with the College of Sex and Relationship Therapists in the UK and the British Association for Behavioural and Cognitive Therapists and the UK Council for Psychotherapists. She is an expert in the field of sexual behaviour, well-being and mental health, and has 2 master's degrees from the University of the Witwatersrand, Johannesburg, and from the University of Sydney in Australia. She further obtained a postgraduate diploma in CBT from Royal Holloway University of London, and holds the European certification as a psychosexologist with the European Society of Sexual Medicine and European Federation of Sexology. She's currently working at undertaking her doctorate in psychotherapy with the Metanoia Institute and the Middlesex University, and has published numerous articles and book chapters, including in the Journal of Sexual Medicine and the ESSM Handbook of Clinical Sexology. Catriona hosts the podcast, which I mentioned earlier, called Asking for a Friend, which tackles topics related to sex, intimacy, relationships, and well-being. Without further ado, Catriona, handing to you.
Thank you so much for the introduction, Anthony. And please could we have the poll for the talk? I think it would be great to bring it up now so that I can see, what your thoughts are. Who is more likely to experience less desire in a relationship? Those who identify as women, those who identify as men, or either partner? And the quote that I have at the start of my webinar this evening, of my talk, I think really is going to speak to what happens with sexual desire discrepancy in the therapy room, which is that sex today promotes desire tomorrow. And I'm looking forward to seeing those results. And Michelle, if you can bring those up as soon as those results are ready, that would be great. So very interesting. So just over half of you attending think that it could be either partner, but then a huge percentage as well, 46%, that those identifying as women, and a very small percent saying those identifying as men. So very interesting, and I'm hoping to. I wish we could run this poll again at the end of the webinar to see if this is going to change your views. But what are we hearing from our clients? So these are some real examples of the stories we tell ourselves about sexual desire, and examples of formed neural pathways that get reinforced every time we have these thoughts and feel the associated emotions. So if you believe that you're just someone who doesn't have a high level of desire, if, for example, when comparing yourself to a partner, then this pathway is reinforced each time you don't feel like sex, but your partner does. So things like, he must be gay because men are supposed to want sex. It's happened in all of my relationships. Sex is great in the beginning and I want it as much as them, but then as time goes on, my desire vanishes, and so on. So why do these thoughts perpetuate, and how are neural pathways formed? Well, I love this quote from Donald Hebb: neurons that fire together wire together. This quote really helps us understand how pathways in the brain are formed and reinforced through repetition. The more that we do a particular action, think a certain thought, or feel a particular way, the stronger that pathway becomes. A neural pathway forms when you encounter a new piece of information, or, for example, a thought for the first time. So I want you to think of it like a pathway in a forest. When you have a thought or hear an idea, such as women have lower desire than men, as 46% of you had thought so, that forms a neural pathway in your brain. The more that you think this thought or feel the associated emotions to it, perhaps that's going to be shame or guilt or anxiety, then that pathway gets reinforced and repeated again and again. And so eventually your brain doesn't even need to try and figure out the way, because the pathway is so clear and so well traveled. So like this path that you can see in the forest, one's thoughts, one's feelings and actions become reinforced the more that we engage with them. So if we constantly think that something is wrong with us because we don't want sex as much as our partner, we are consistently reinforcing this neural pathway. So to give you an example, if a little girl touches herself, as we know, it's very normal for young children to do that, and her parent, her caregiver, shames her for it, she's going to learn to associate that soothing sensation, which was why she was touching herself, to something that is wrong, something that is shameful, or something that is negative. Now, the first time that message is received, a neural pathway is created in her brain. And anytime she hears a negative message or feels shame about wanting pleasure in that way, the neural pathway gets used again and gets reinforced. So the brain not only creates a pathway that associates pleasure from touching myself to the thought I've done something bad or wrong, but it also creates a pathway associated to the emotion that the thought brings up. And so every time we think in a certain way, we do a certain task, or we feel a particular emotion, that pathway gets strengthened. And unfortunately, because messages about sex all around us are, for the most part, quite negative or sometimes neutral, which is not helpful either, this pathway is going to get reinforced time and time again. So when it comes to therapy, we need to create a new neural pathway and let that old pathway grow over, as you can sort of see in this picture. The more that we travel the new path, the easier it's going to get for our brains to remember that there is an alternative path to travel. But as you can see in this picture, the pathway is still somewhat apparent, and it doesn't simply disappear. It's going to take time and repetition, and often constant conscious repetition, traveling on the alternative path before the kind of, old entrenched neural pathway is no longer in use. This is neural plasticity at the core. So how do we do this in the therapy room when we're treating differences in desire? We need to focus on decreasing distress first and foremost. This is the most important thing, and I'll explain a little bit about why that is in a moment. Then we should be aiming to increase pleasure by broadening the sexual repertoire, changing the sexual script, and bringing about mutual agreement on what sex looks like and why a couple has sex. Again, a really important point I'm going to speak to in a moment. We are not interested at all in the frequency of sex. I need to repeat that. We have no interest in frequency. This has been found to be the lowest predictor of sexual satisfaction in study after study. And I love this quote from McCarthy and Farr. We need to balance each partner's sexual autonomy with being an intimate team who integrate intimacy, pleasuring, and eroticism into their relationship so that sexuality plays an energizing role in relational vitality and satisfaction. So, where do we start? How do we change these pathways? First and foremost, it is crucial that you conduct a thorough assessment, and this needs to take place with the couple and with each partner individually. This is going to be based on the premise that, if there is evidence for a medical investigation, that a medical investigation has been undertaken and medical causes have been ruled out or managed. In general, couples will not consult for sexual desire discrepancies, but they will present the problem as one partner suffering from low desire. In my clinical opinion, we need to stop thinking of it as low desire and focus on it as differences in desire. We do not need to fix the person who wants less sex because there is nothing to fix. What we are there to assist with is sorting out the distress that is present. Once we've done all of that, we want to ask the couple in this assessment if they talk about sex. Because let me tell you, people do it, they just do not talk about it. Then what happens when they talk about sex and how they communicate in general? Then, we need to be asking about desire. How do they each understand and define it? What are their expectations of themselves and others? And often the partner who presents with lower sexual desire relative to their partner is pathologized due to their use of their partner's relatively higher level of desire as their benchmark for normal. Then we can move on to treatment. Now, obviously, you need to choose an appropriate treatment that's going to be suitable to your clients, even if you use an integrative approach. And I'm going to speak to a few different psychotherapeutic approaches that are useful in this context. But I do want to say that there is no evidence-based treatment or protocol that you can follow for sexual desire discrepancies, and you must work holistically and individually. And, couples generally need to learn the truth about sexual desire, as well as the skills to manage their distress before in-depth treatment. As I said about the aim of treatment, this is fundamental, is managing the distress. So Jim has obviously given us a brilliant understanding of what's going on in the brain and what desire is all about. And you are not going to be able to help change the way that your clients think about sexual desire if you don't know the facts yourself. So psychoeducation plays a massive role in forming new neural pathways and reinforcing them so they become the more traveled path. So let's look at just a few things that we really need our clients to understand. The first one that is so important: desire is a state, not a trait. It doesn't rhyme if you use the word trait, so we're going to go with trait. Desire is a state, not a trait. It is something you experience. It is not who you are. Unfortunately, we so often see our clients taking on low desire as an identity. Then, sexual desire fluctuates. It varies, and it is context dependent. If you know the work of Emily Nagoski, she speaks to the absolute immense value of evaluating context in relation to sexual desire. And if your partner initiates sex after you've had the worst day with work and the kids, you're not likely to be receptive. But if they initiate on holiday, we all know that that's a very different result. Then I want to come to what I had pulled up in the poll question. So Michelle, can we, we've done it already, sorry. What I want to say with the poll question, men and women, what research is showing us is they actually experience both. They both experience lower desire, as do couples. And we need to move away from the narrative that it's just women who experience low desire, as it not only pathologizes women, but it's harmful and stigmatizing to our male clients. We also need to move away from narratives such as lesbian bed death. This has nothing to do with lesbian couples and everything to do with stereotypical narratives around women's sexuality and obviously very pretty well-traveled neural pathways. Then this last point here on the slide is crucial. Desire is never spontaneous. I want to repeat that. It is never spontaneous. Spontaneity is always the result of careful planning. We have to get off this path of thinking that sex just happens. Our desire for sex most often only comes up once we are already having sex. And as Jim pointed out, responsive desire from Basson's model is crucial to sexual desire experiences between a couple. We do not just feel like sex and get turned on and experience arousal. There's actually some evidence to suggest that engaging in sex, even when we don't necessarily have desire for it, can actually be good for the relationship. Then we need to help normalize this. All couples will experience a desire discrepancy, maybe at some stage, maybe throughout their relationship. The sooner our clients accept this, the less impact on the relationship. And research actually shows us that if couples accept sexual desire discrepancy as a normal part of their relationship, it actually makes that couple more resilient when the discrepancy occurs. What people think desire looks like and what desire really is very, very different. And Jim, again, touched brilliantly and wonderfully on the notion of how powerful expectation is. It can quite literally change our hormonal experience. As I said, couples therapy is really important in this context if medical causes have been ruled out. And if they've been ruled out, this is a couple problem. It's not the individual problem, because by only treating one partner, you're going to unwittingly pathologize the partner that experiences less desire and create a perspective that in order for things to change, only one partner must do the work. We have to move away then from the what, the differences in desire, to the why, the motivations. Why do they have sex? Why are they distressed about the difference? And then something that's really fundamental before you delve into deeper therapy is teaching them how to communicate properly. So teaching the couple how to talk about sex, this actually requires practice. And this can be done in the session or as an exercise for them to do at home. The homework tasks are fundamental as part of psychosexual therapy, and ultimately they help to reinforce new neural pathways. Giving exercises means that they're actually scheduling time for sexual intimacy. And as I've said just now, sex is never spontaneous. And when it comes to communication, you very often have to help the couple develop a language around sex to become more comfortable talking about sex, because it's the elephant in the room, but also to teach them to say no thoughtfully, to say no to sex thoughtfully, and to hear no openly, so that it doesn't feel like a rejection of the self. So let's look at a couple of treatment approaches that we would use in psychosexual therapy. And Jim has mentioned a couple of these already that are really effective. So mindfulness is a form of neuroplasticity. And what we know about the effectiveness of mindfulness is that it is about the consistency that's going to bring about the biggest change in our overall well-being and day-to-day life. And that is because there is a repetition of new neural pathways. The brain develops those new neural pathways, and through mindfulness learns to be less reactive, more in the moment, more compassionate, and more curious. And all of those are really great for sex, for everything from arousal to desire to orgasm to the connection that a couple feels. Interestingly, people with lower desire are often not present. They spend the entire time worrying about the fact that they have lower desire. Then we can use something like cognitive behavioral therapy. Cognitive behavioral therapy directly addresses challenging pre-existing thought patterns that may be interfering with desire. We do this through cognitive restructuring. We can use techniques such as behavioral activation, where we are getting the couple to plan intimacy, to be intentional with sexual closeness, learning to prioritize sex. And when I say sex, I do not mean penetration and intercourse. I mean everything that we do sexually in their relationship, and thus expanding the sexual repertoire. And then teaching them skills, much like with mindfulness, to manage anxiety and distress, to manage shame and guilt, so that they increase their ability to cope with the differences when they occur. Then there are two different approaches. They're quite opposing, but both very effective. The first is the emotion-focused therapy from Dr. Sue Johnson. So if we utilize this approach in therapy, which has been proven extremely effective for couples therapy, we are focusing on unmet attachment needs. Attachment style and attachment wounds, they stem from childhood, so from neural pathways that are being formed as a child. And if we experience unavailable caregivers, we may grow up to turn to sex in order to feel closeness and thus emotional safety in the relationship. And so if one partner doesn't want to have sex as much because their motivation for sex is not driven by attachment needs, their partner could experience immense distress if they seek out sex for feelings of safety and closeness. So sex is actually an attachment act. If we have somebody who has an anxious attachment style, they will often display higher levels of desire, but it serves to restore emotional closeness. And if we have somebody with an avoidant attachment style, they will often display higher desire in the early stages of a relationship, but lower desire in the context of the relationship. If a couple has a secure attachment, it actually serves as a protective factor for desire discrepancy. And then to mention our wonderful colleague, Esther Perel, who I'm sure so many of you know, her view of desire is about differentiation. She says that for desire to be present for a couple, they need to have space and time apart. We need separateness. And as she puts it, mystery, intrigue, and adventure, and looking at your partner through a new gaze. Too much intimacy can smother sexual desire. And there can be such a thing as too much closeness between partners that it results in almost a de-eroticizing of each partner. I think it's crucial here to say that the pandemic has actually exacerbated this hugely. I've seen so much of this in my practice. During hard lockdowns, when we were all at home, when everybody was in each other's space, there was no space and time for separateness. There was no space and time to miss each other. You can think of it like a flame. A flame dies if there is no air. So in therapy, this is about helping the couple find ways to miss each other and shift some focus to doing things separately in order to come together. And then finally, to touch on sensate focus, which is one of the most fundamental techniques that we use in psychosexual therapy. This is crucial in helping the couple expand their repertoire, adjust their view of their sexual script, discover new things that they can do sexually together and about each other's pleasure, and shift the focus entirely from performance, I have to feel like sex to have it, to pleasure. This feels good and I'm open to seeing where this goes, but I don't have to go anywhere. So in a snapshot, when it comes to treating sexual desire differences, and I think I want to say, you notice I don't say mismatched desires. I speak very clearly and specifically about desire differences. Mismatched means that there's something wrong there. With desire differences, we need to normalize this experience for couples and depathologize the experience. We need to focus on positive and realistic expectations. Desire doesn't need to come first. We may start having sex and only once we're having sex, desire comes up. We need to challenge our preconceived notions of sexual desire, both as ourselves, as clinicians, personally as well, and with our clients. And we need to empower our clients in open communication. By doing all of this, we are going to decrease distress and increase pleasure because we're broadening the sexual repertoire and we are developing a shared sexual script. Now, regardless of the route to treatment, differences in sexual desire should be treated in the context of the relationship. So even if you are treating it from a medical perspective, you need to be taking the context of the relationship into consideration. Desire discrepancy itself may not be problematic, but when it is deemed problematic by the couple, it can lead to issues that may benefit from treatment. So in trying to create and reinforce new pathways, you really want to try and change the client's thought processes from, do I feel like sex, to can I be open to experiencing desire should it come up? And I'm going to finish off by sharing with you some really helpful resources. Dr. Kristen Mark is particularly knowledgeable and an excellent teacher when it comes to desire research. Dr. Karen Gurney's book, Mind the Gap, is really excellent for yourself and for clients to read. Obviously, I mentioned Esther Perel, both her clinical work and her work for our clients, Dr. Sue Johnson, emotion-focused therapy, and Dr. Laurie Brotto, who is a fantastic mindfulness researcher, and again, has written an excellent book, Better Sex Through Mindfulness, which is fantastic for yourselves and for your clients.
Catriona, thank you so very much. That really was an excellent presentation, and I think incorporated remarkably well some of the subject matter that Jim covered earlier with a very pragmatic, real life orientated approach, which I think many clinicians in the field can very strongly identify with and certainly learn from. So we've been inundated by questions here, so I'm not entirely sure where to start, but I'm going to start with the really the idea of desire discrepancies and some of the ways in which these discrepancies present themselves, and also in the ways in which various couples try to actually get around them. So there's two parts to the question. The first one is a question about polyamory, which is a way of being, when there are discrepancies within a couple, how does that play out if a couple then becomes more than a couple, and how is that managed, and are these problems that you're experiencing at the moment? And then I have a question about kink and a very highly focused desire, which is very, very focused, but we'll come to that. So maybe in the first instance, that first question about reconceptualizing desire discrepancies when there's more than one, there's more than two people in the relationship?
Well, I think desire discrepancies can happen whether you're in a couple, in your throuple, no matter how many people are in the relationship. But it depends on individuals' needs and wants when they're experiencing desire for sex and arousal. Ultimately, whether you're two people in a relationship or more, open communication is probably the most important thing. But again, to understand that desire discrepancies are normal in any sort of relationship. They are expected. Again, context is crucial. If we, my practice has been inundated with people experiencing, lowered desire and desire discrepancies in the past 15 months because of the pandemic. So I think that whether you are in a relationship with one person or many people, it's important to expect that it can happen, and it is very likely it almost will happen, and to have open lines of communication around it so that when it comes up, you're able, as that kind of threesome or whatever, however many people are in that relationship, to discuss it openly. There are so many ways for couples to connect and throuples to connect intimately. We don't have to have sex to gain closeness in a relationship.
Thank you, Catriona. I think before we move on, just addressing this other question where desire has become so focused that it's become a huge area of discrepancy. And there's a question here about a 35-year-old man who has a very particular kink around high heels crushing his skin, a fetish around this, and is unable to get erections from any other type of sexual activity. And this is within the context of a couple who do communicate pretty well, and also somebody who doesn't feel guilty or feel hung up about his fetish, and nevertheless is having difficulty in being able to reconcile the sexual needs of him and his partner.
So, what's interesting there is there's no distress, there's no hang-ups about it, but there is the desire to be able to experience a certain level of arousal with a partner, perhaps without this kind of kink. So for me, this is about almost like neural retraining. And it's going to take some time to work through something like this. Open communication is obviously really important here. Again, communication is the cornerstone of therapy as it is. But I think for an individual like this, within the partnership, it would be really, really helpful to be on almost a retraining program to help the brain get used to and adjust to different sorts of sensations. Sometimes what can happen is we get so fixated on a particular sensation and we can only achieve a certain level of arousal from that particular sensation. It desensitizes us to other sensations. So we need to retrain the brain to experience that. So if that's removing that sensation entirely, although this individual is not distressed by it, so there may be the need to try and integrate the ability to have that particular sensation from the high heel as well as other sensations. And I think mindfulness may be a very useful approach for this person to be utilizing.
Catriona, that's really terrific. And I think it whets our appetite for further discussion at the end. So thank you for that. We're going to take a short intermission now. We have got 5 minutes to allow you to stretch your legs, go get a drink, go to the loo, just prepare yourself for the next installment. So we'll be back in 5 minutes.
Who are we? We are not sellers of drugs, not mere manufacturers of medication. What we make are memories. Memories that may not have been there to be remembered had a life not been lived. We make people better, and we save lives. And we make time too. Time we gladly give to those who have learnt what so many of us have forgotten. The value of every single day. The preciousness of every breath, of every heartbeat. We make tears, tears of thanks for the release from pain. And then there's hope. The hope parents have for the happiness of their children. You see, we don't have a strategy, we have a cause. We don't have a vision statement, we have vision. We see a future where good health is expected, not for the few, but for the many. And we don't have consumers or a target market. We have Alison, Seb, Topeka, and Zunaid. And that is why we are not a healthcare company. We want people to live a long and healthy life. Some call it human care. We call it caring for life.
We are ready for you, Woet.
Okay, thank you very much. So back after a 5-minute break. Now I want to introduce to you Dr. Faysal El Kak from Lebanon, from Beirut. Let me read this. He provides integrated obstetric, gynecological, clinical services, teaching and training of residents, academic work, and research related to women's health, sexual health, and public health. He's the director of the Women's Integrated Sexual Health Program, the Department of Obgyn of the American University of Beirut Medical Center, where he provides specific reproductive and sexual health services to women across their lifetime, including postmenopause and cancer survivorship, post-surgery, and postpartum. As a researcher, he's involved in and has co-led research on maternal health, sexual and reproductive health, violence against women, and refugee health as well. Dr. El Kak has authored over 50 publications, as well as multiple books and book chapters related to sexual, reproductive, and maternal health. He's a senior lecturer of health behavior and sexuality, faculty of health science, American University of Beirut, as well as the vice president of the International Federation of Gynecology and Obstetrics. Faysal, the floor is to you.
Thank you very much. I want to thank also Sasha, was my friend Elna, Anthony, and yourself and the whole team for inviting me and for partnering with FIGO, which sends a very strong message as we are being inclusive as WAS, and also as FIGO is trying to push also sexual health problems to be also addressed by gynecologists, being the first providers of care or the primary providers of care for women. I want to build on what Jim and Catriona have said in terms of non-judgmental in terms of desire for both men and women, and also for the beautiful neurophysiologic elaboration that will really inform what I have to tell you in terms of the challenges we might face as a clinician, particularly as a gynecologist, the process of care, and some of the CNS and hormonal treatments available. I have nothing to disclose. As Jim has said, it remains really challenging to understand the issue of desire, because within a clinical perspective, you're talking about desire as an incentive, a motivation component, and arousal as the excitement or the arousal component that's affected by time, by age, by gender, and other factors. And also, as Catriona challenged, people think it's stronger in men and more diverse in women. Well, also it's a case by case, and it's important that we shift from dysfunctioning or pathologizing into normalizing within the clinical setting. What some of the researchers argue that it is the interface in relation to women, the interface between the desire and the arousal that will allow to incentive motivation that leads to the central arousal, and at the same time gives this, as I call it, the shades of desire, ranging from the to be desired to the sexual pleasure, perception and feeling, and to the salutary scale. These ranges of desires that might present in the clinic, plus the issue of the object of desire, has bearing on clinical presentation, what women experience when they present and they complain of loss of desire, and also has a bearing on the available treatment and how to go around it. You see women present, as I said, during pregnancy, in the postpartum, in midlife, with related reproductive health problems, perimenopause, postmenopausal, post-surgery, post-chemotherapy, and cancer survivorships during adolescence. So in all walks of life, in health and in illness, and you have to be ready at least to listen, advise, and refer. Is it prevalent? Yes, it is. It is prevalent. From the various studies, you can see various numbers, and why you see various numbers or percentages of prevalence, because it has to do with the definition of the low desire, the type of participants, and the methodology. But whatever considerations you have among all the published papers, it is somewhere between 17 and 50%, which is something really to consider. And most importantly, it varies across age. It varies in the reproductive versus the postmenopausal, whether it's natural menopause or surgical menopause. And at the same time, in the famous PRESIDE study, we all have seen that there is an association across the various domains of sexual dysfunction and distress, and that marks the clinical definition, or the actual definition that presents in the clinic, is the low desire associated with distress, as was seen in the PRESIDE study, with 10% reporting desire as a sexual problem and distress at the same time. In that paper, there was a conclusion that around 8 to 10% out of 40 who complained of sexual problem and low desire, 8 to 10% have met the criteria of hypoactive sexual desire disorder. This is a clinic-based study for a woman presenting to around 20 OBGYN and primary care clinics. And again, around 8% had hypoactive sexual desires that was not affected by levels of education or sociodemographic factors. And unfortunately, only 50% of those will be seeking care or sought care for this problem. From another community, another population in Australia, midlife women, again, the prevalence of the desire was around 70%. Those with distress around 40%, making close to 33%, again, the prevalence of hypoactive sexual desire. As I said, that varies with age, and from reproductive, again, to the postmenopausal, whether natural or surgical. So it is prevalent, it's coming to the clinic, and you have to deal with it. So women can be presenting to you with distress, persistent distress, and persistent dysfunction, and at the same time, interpersonal difficulty affecting their couple's life. The clinicians, they have a different perception. Some of them are willing, some are not, some are competent, some are not. Some they have time, others they don't. So it's a challenge to deal with this encounter. What we follow usually is to follow this classic definition as by the ICD-10 and also in the ICD-11. You're talking about decreased or absent spontaneous desire for a minimum of 6 months, or decreased or absent responsive desire to erotic cues and stimulation. At the same time, there is a loss of desire to initiate, and also there is an association with the personal distress. And this is, of course, will set the base for our differential and assessment later on. But the challenge remains, as Jim said, in the DSM-5, we moved from the low desire into the interest arousal, whether this is driven by pharma or by other encounters. Apparently, people are not very happy, or at least most of the people are not happy with moving from the desire to the interest arousal. And the other challenge, as I said, is the clinical encounter and the ability of the woman or the comfort of the woman to speak out, or the comfort of the providers to deal with the topic. This is from the International Society for the Study of Women's Sexual Health, the process of care. Of course, you start whether using the allow or the implicit models. You ask for permission to discuss whether the person is sexually active or not. Then there is, if there is a response of low sexual desire and interest, you go for the assessment using the decreased sexual desire screener, the DSDS. And this is 4 questions that are related to level of desire or interest, okay, whether yes or no, the answer. Been a decrease in your level of desire, are you bothered by your decreased level of desire, and are you willing to improve the level of desire, okay? Then you have a question 5 that looks at the modifying factors or contributing factors, whether it is a mental health or a physical health issue. As a clinician, you should look at this in the following way. If the patient says yes to the questions 1 to 4, then definitely, and no to the question 5, then definitely you are dealing with generalized acquired HSDD. If there is at least 1 no to any of the questions from 1 to 4, then the woman or the patient or the client doesn't qualify for the diagnosis of generalized acquired HSDD. If there is a yes for 1 to 4, and there is yes across the 5, then you might think of HSDD being a primary diagnosis, or it is secondary contributed by some of the chronic health problems. So once you do the assessment, you start to look for the modifiable factors, if you have them, from the response on question 5, okay? And if there is no modifiable factors, if there is no modifiable factors, then you continue with the education as Catriona elaborated on. If there is a potentially modifiable factors, then you have education, and then you try to deal with the, call it medical or call it the physical and the mental contributions. And in this case, when you're left with the HSDD without the modifiable factors, then you decide if the woman is premenopausal. Of course, there is the sex therapy and there is the CNS agents. If she is postmenopausal, you add on top of that the hormonal therapy and you do your follow-up and assessment. Of course, once you're sure of a generalized acquired HSDD, then you have to dwell more on the sexual history, looking for low motivation for participation, loss of fantasies, low desire to engage, respond, or oblige. This is a very interesting paper looking at what can contribute to the issues of low desire, like sexual arousal and lubrication problems. And in this paper, 85% cited multiple factors like stress and fatigue. This is something you can get from the sexual history, dissatisfaction with my physical appearance, and other sexual difficulties like orgasm. On the other hand, combined lubrication and arousal problems can go up to 42% in those coming with low desire. Okay. The prevalence and association with arousal lubrication problem, again, is around 40% in the premenopausal and around 50% in the postmenopausal. So it's very important that we dwell on the sexual history, and at the same time, we should be able to identify the modifiable problems. For example, diabetes, hypertension will really set it like multiple times the impact on low desire. Endocrine problems, neurologic problems, and psychiatric disorders, they all contribute. As for the physical exam, of course, you do a general physical exam. As for the pelvic, in the pelvic exam, you try to look for any lesions, ulcerations, infections, any component of vaginismus that's causing sexual aversion, as Jim alluded to. And for the labs, it depends on a case by case. You don't have to do any lab unless you are dealing with, or you want to investigate in our case, certain medical conditions, or you want to assess the hypothalamic pituitary ovarian axis. And of course, you check the use of drugs and medications that are associated with low sexual desire, anti-epileptic drugs, cardiovascular, antihypertensive agents, hormonal medications, some of the even OCPs that are containing anti-androgenic progesterones, psychotropic medications, and others. What are the treatment modalities available besides what Catriona discussed and elaborated? Well, first of all, for a clinician, you have three situations and you have one concept to remember in the clinical practice. The situations are you take a calculated responsibility for using certain products of labor like testosterone and others. You ignore and you shift the focus to other topic, or you act indirectly at sexual level by prescribing treatments for pelvic genital reproductive problems, assuming they might be helpful in treating low desire, and this happens with some of gynecologic practice. The other concept you have to understand, we said three situations and one concept. The concept is the sexual desire, we know by now, results from a subtle balance between excitatory and inhibitory nerve pathways. And this also was mentioned by Jim. Just for us to remember, there is a hyperactive inhibitory response and the hyperactive excitatory response. It all goes back to the dual model. So you decrease inhibition and you increase excitation using the proper medication for that regard. So this is the kind of protocol that we use for the treatment. You have the first line, you have the second line of treatment, and then you have the third line, which is sex therapy, including the CNS agents and the hormonal treatments. The CNS agents are the flibanserins, bremelanotide, bupropion, and buspirone. And the hormonal ones are testosterone, tiburones, estrogens, and a combination of more than one hormone. The flibanserin is a very novel drug. It is a mixed postsynaptic 5-hydroxytryptamine agonist and antagonist at the same time. So it decreases serotonin levels, increases dopamine, norepinephrine levels, and that makes it different from buspirone and bupropion. Flibanserin works on the prefrontal cortex by enhancing excitatory elements and listening inhibitory response to sexual cues. Again, increasing excitation and lowering inhibition. It's taken as a 100 milligram tablet once daily at bedtime, mainly approved for premenopausal, but there are more recent studies suggesting its efficacy for the postmenopausal. There is plenty of studies that are reviewed in the recent paper by Ann Clayton, and these are all the papers and the studies done on flibanserin, which has been really challenged more than once before the FDA approval. The famous Begonia trial for the premenopause, the Snowdrop trial for the postmenopausal, the Plumeria for the postmenopausal, and then because of the associated side effects with this regarding the hypertensive attacks, regarding drowsiness. So again, it has been studies with the alcohol challenge and alcohol use and analysis, and all of these have been reassuring, which made the FDA now send a new safety labeling change notification, eliminating the black box or the warning box from flibanserin and allowing its use even if there is like few hours between the pill intake and the alcohol intake. So the flibanserin remains a new major mainstay. The other one is the Velisi or the bremelanotide for the premenopausal. Again, it's a melanocortin receptor. It's very important and useful for the acquired generalized hypoactive sexual desires. And it should be not due to a coexisting medical or psychiatric condition, or there should be no problem with the relationship. Again, Clayton reviewed most of these studies, again, towards showing the impact on desire using FSFI and FSDS, and showing improvement in addition to satisfying less stress and satisfying sexual events. This is the Reconnect study data. If you are interested in looking more at this drug, it again shows the improvement in the study versus placebo in terms of the improvement in the FSFI indices, and in terms of again reduction of distress as another primary endpoint. There are some of the side effects that exceeds 4% of the participants, like nausea, flushing, headaches, and vomiting, which is very important as you advise your patients on this use. Well, bupropion was studied in earlier research with the slow release of 300 milligram per day, and also has been shown compared to placebo to improve sexual function. Remember, bupropion is a dopamine and also norepinephrine reuptake inhibitor. More recent work had been shown on adding bupropion and trazodone. Trazodone is a sedating inhibitory serotonergic agonist antagonist, and the substance is called Lorix. again reviewed by Pike and Clayton, Popropion and Trazodone over 4 weeks, and it has been shown again to improve using FSFI and FSDS the levels of sexual desire. In a more recent one regarding those findings, again, it has been shown to be very helpful in the premenopausal women with hypoactive sexual desire disorder. So more and more we're having really help coming from the CNS agents that emphasize again the importance of the brain and the importance of these drugs really driving the positive channels in the brain to improve the desire. As for the hormones, this is a very excellent paper in the Fertility Sterility Journal looking at, it's a review by Akili looking at the testosterone in the postmenopausal. It reviewed the 7 RCTs, and there was an excellent improvement in the satisfying sexual event and sexual desire by using testosterone patch versus a placebo. But this is not convincing yet the FDA to use it because transdermal testosterone for women is limited to unregulated formulation or to using some modification of the men formulation. And this has been shown to have some side effects like acne and hirsutism, but no serious long-term effect on liver and physical health had been reported. The other combo, which is very kind of new, it's a personalized kind of treatment, because people assume if you have an issues in response to sexual cues, that's one thing. If you have another issues that has to do with inhibitory mechanism, that's also another thing that you can handle. So it's about sexual cues and sexual inhibitions. In case of you have a problem with the cues, people thought, why don't we use sublingual testosterone, okay, combined with sildenafil. So you're combining the cortical response and the genital response at the same time, and that's the commercial name of Libido. Well, if you have a dysfunctional activation of the inhibitory mechanism, you can still use testosterone 0.5 milligram with pospirone 10 milligram to release inhibition and improve also at the same time the cortical response. This is how it shows for the, you can see when testosterone kicks in, and then which is followed by the sildenafil for the genital preparation, and the same thing also for a reduction of the inhibition. So this is a kind of a personalized kind of treatment.
Faysal, can you close down?
Yes, I have 2 slides. The other important one is the estrogen, and we have been with estrogen as gynecologists for a long time. It has not been shown by Cochrane review to impact sexual desire. Also, testosterone that we use for the menopausal women doesn't interfere with the sexual desires. However, in a recent paper, combining estrogen with testosterone in higher doses have been shown to really impact and improve levels of sexual desires. In brief, you're moving from a pre-treatment of high inhibition, low excitation, into a post-treatment of high excitation and low inhibition. As FIGO, definitely we encourage our gynecologists to have the opportunity to screen, counsel patients with a low sexual desire and work with therapists to develop psychotherapy treatment plans for these women. I want to thank you very much for this opportunity, and I hope more and more gynecologists will engage in dealing with female sexual dysfunction issues. Thank you very much.
Thank you very much, Faysal. So now we immediately go to the general questioning time. Anthony, you have the first question ready?
Thank you, Woet, and thank you, Faysal, for that. Oh, there's so many different questions, I think, which have come out of this. So we're going to do our best to try to abbreviate them and perhaps collapse them in a little bit. And there have been quite a few questions on desire, how it affects the different genders differently, how it presents, whether in fact these are more social and cultural constructs, how this pertains to transgender and gender diverse individuals. We're seeing there's more to a greater degree, and how they present within the context of the clinic. So it would be interesting for perhaps each of you to be able to answer from your different perspectives on that. Maybe Jim to start.
That's a huge question, obviously. I mean, I think that there's people have not done enough in transgendered individuals to actually look at how their desire has changed with the degree of, the kind of surgical and hormonal replacement that they may get. That needs to be done. I think that's a hole in the literature, a black hole that needs to be filled. In terms of men's desire, I mean, that's like one of the big elephants in the room. We're always supposed to be, tonight and be ready to go, but it's like, men suffer desire disorders like women do. It's men just don't complain about it because we're not supposed to complain about it. And, and when that does happen, I think, again, it's the elephant in the room. Would bremelanotide work in men? It does, but yet that's not what the FDA has approved it for. And of course, because there's no discussion about this, our desire just seems to be taken for granted. When men go through, a hormonal decline, when you get testosterone insufficiency in men, desire goes away completely, as Woet had in his second patient. So I think you're really dealing with. I mean, we're at kind of the tip of the iceberg here when it comes to understanding desire and understanding how desire is affected by effective sexual pleasure. And that's all I'll say.
Thank you. Thank you, Jim.
I
Catriona.
think maybe I can speak to those who identify as women versus those who identify as men, and the way that sexual lowered sexual desire is portrayed. I think often for those who identify as women, there is almost an acceptance because of that neural pathway that exists and the narrative around women's sexuality that women just don't want sex as much. But as Jim just touched on with men, there's a lack of acceptance. So there's a real silence around men who experience lowered desire. They don't speak up about it at all. And I know in my practice, I've seen more and more men lately, but they don't speak to anybody else about it. It's really a taboo subject. So with women, it's almost, it's not acceptable. I don't want to go there at all, but I'm almost expecting myself to experience low desire because I'm a woman or identify as a woman. And I should not experience low desire because I'm identifying as a man.
Thank you. Faysal, any thoughts from your side?
I can just agree with my colleagues. I have just to say one thing. I've been in the team of transgender sex reassignment surgeries. And I believe when people move from the gender dysphoria to gender acceptance, definitely they feel much better about their sexual identity, sexual perceptions, and definitely about the sexual desire. I have seen them when they are dysphoric, having serious sexual concerns, including low desire. And in the post-sexual reassignment surgery, things have been different. And even those with the cross-hormonal treatment, they felt much better because they felt more comfortable in their gender.
Okay,
yeah.
I have a question for both Faysal and Catriona, and that's about the population above age 75. Do you see aged female or male patients with desire problems? And if so, do you have comparable treatment recommendations? Faysal, you first? No, Catriona, you first?
Okay, sure. Sure. So I think that the thing that's important to remember is sex doesn't stop just because we age. sex is just going to change. So when we're seeing these clients in practice, and I would say it's more rare, you know, because there is, again, an expectation that as I get older, maybe I'm just going to stop having sex. It's about navigating the new normal as we get older. You know, achy joints and mobility issues and things like that need to be taken into consideration. So I think that we really have to help these clients and not disqualify them from the conversations around sexual desire, because we often do, to actually figure out how they can still engage in sexual closeness and intimacy, despite the fact that maybe they're not having penetrative sex anymore, or intercourse, or any type of physical sexual acts.
Yeah.
Okay,
Well,
Faysal. Yeah.
To add to this is from the medical treatment perspective, definitely it's very important that you change perception, you engage them in a different lifestyle, in a more positive lifestyle, based on the Passon model and what Catriona has said. In addition, we use a lot of lubricants, moisturizers because of vaginal dryness. We use also progressive relaxation in case there is some tightening of the vagina from a medical or by age effect. But remember one thing, there is no clear-cut proof that age or low androgens or testosterone levels in women, they change so much with age and the postmenopause, and they affect the desire. It's mainly a perceptive thing and probably a mechanical thing that has to do with their physical mobility and the genital well-being in this case. So we deal a lot with this: testosterone treatment, moisturizer, lubricant, topical estrogen, low-dose estrogen inserted in the vagina. They help a lot because in this case they can have dyspareunia, and dyspareunia can affect the desire, and low desire makes an aversion and stuff like this. So you start dealing with one case at a time, and they do much better. Yes.
Thank you.
Great. Woet, maybe I could ask a question on off-label, not really off-label, but alternative forms which people are utilizing in order to increase their desire. There's a question on the role of cannabis, obviously increasingly prescribed, herbal medications, potentially what has been used and for which there's evidence, and there's quite a lot of talk in mental health circles around psilocybin and quite a lot of and increasing amounts of research done on that. And I'd be interested if Jim had any thoughts on how that, as a very new novel type of embryonic type treatment, may be adapted to the problem of sexual desire.
Well, I mean, cannabis at least has a few ongoing clinical trials, especially with CBD versus THC. Or just, you know, a joint with both of them in it, right? So how does that affect? I mean, one thing that's very clear is that you can, within a certain dose range, cannabis, like alcohol, can induce disinhibition, especially if people have anxiety around sex or have some kind of, you know, an inability to kind of engage sex and disengage from all the other things that are happening in their lives. So I think that's one way that cannabis, either whether it's THC or CBD or some mix of the two or some different proportion of the two, is working. In terms of herbal remedies, you have, I mean, canna, there are plenty of things that are out there that will essentially activate the excitatory pathway. So those are being looked into, and they could even excite, you know, or intensify the experience of orgasm. In terms of psilocybin, that's really intriguing, because if you are wrought with anxiety, depression, other things that are, you know, that very microdosing psilocybin is now showing can reduce the effects of, well, I mean, one of the things that happens with depression and anxiety is you lose your sexual desire because you're overwrought with other things. So that's something that you could very easily imagine sexual desire may come back in people that are microdosing, but there's no clinical trials yet. So, I mean, I'm supposing what might happen, but until we have clinical trials, we really don't know.
Yeah. There are probably, Anthony, a couple of papers on Argin Max and other products that work on improving sensitivity of the genital area and of the clitoral area. So by like improving perfusion and making it more sensitive, people think this will probably engage women more in the sexual activity because they think they are now more, this is the responsive part of desire. As Jim said, we don't have a very hard evidence on this, but that's the assumption or the hypothesis behind these, some of these herbal products.
Okay, I have one funny question here. When there seems to be an ongoing real lack of chemistry from one partner to another, where one partner seems to have lack of desire or even aversion, which has always existed despite therapy. I'm curious how you react on that. Catriona, could you do that?
I think maybe Jim should also speak here a little bit to the neurobiology of chemistry, but I think there are two separate concepts, lack of desire and sexual aversion, but they obviously go hand in hand. So chemistry is a very, very interesting thing. If we see somebody across the room and our brain registers them as somebody we are attracted to or somebody we're interested in, it's going to result in a chemical and hormonal response in our bodies. And so we're going to feel good about it and we're going to want to respond to it. But this is a really interesting question, actually. And I actually posed a very similar question to Esther Perel when I was with her in New York once. Chemistry, if it's not there in the beginning of a relationship, it is not something you can magic up in therapy. It is not something I'm aware of that you can take a pill for. But I'm very interested to hear what Jim has to say from a neurobiological or a psychological perspective about chemistry.
I agree with you completely. I mean, really, it's like if you don't, therapy's not going to do it. There may be some, lucky circumstances in which you both, are in a war-torn situation, or you look at people that supposedly on film get together after a zombie apocalypse. I mean, if you're going to experience these things, these horrific kinds of things, maybe saving each other's life can produce can make you go from being friends to being lovers, maybe just experiencing sex together. And if you're the last person on earth with another individual, you have sex with that individual. People have sex in prison. Men have sex with men in prison and sometimes fall in love. So yet they maintain they're heterosexual. How does that work? What's happening in their brains? There's no way that we understand that yet. So there may be freaky circumstances that can work, but by and large, if it isn't there at the beginning, you can't pray it to be there.
Wonderful. Jim, thank you so much. We're going to close down the panel discussion. There's so many questions which have not been answered yet. So I'm really sorry that we haven't been able to address all of those. But I'd like to thank all the members of the panel for their outstanding talks and contributions, and really bringing together from the neurochemistry through to the clinical, through to the medical room, and covering a really wide range of fascinating topics. So I want to thank you all and hand over to Woet briefly to say goodbye and conclude as well.
Okay, then I want to thank you all very much. And I think let me hand it back to Elna. Thank you, co-moderator. Thank you, presenters. Elna, the floor is for you.
Thank you very much, Woet. And thank you so much to all of the presenters. You see now why I said that these would be the people that I would choose for one exclusive dinner party at my house, because it is just, I could listen to them for another few hours. And if you got only 10% of Jim's talk, don't worry, I'm in sexual medicine full time and I only get about 10% of it. These talks are already on the Sasha as well as the WAS Facebook pages. So you can go and rewatch this webinar immediately on Facebook and on Facebook of WAS and Sasha. And then I would just like to thank Cipla again for sponsoring tonight's event and for making this possible. Thanks again to all of the organizers from Sasha for making it possible. And a last thank you to the speakers for your time, for your enthusiasm, for sharing with us so authentically. This talk will be rewatched many times. I'm very certain about that. And then I would like to invite you to become a member of SASHA or of WAS. If you're in South Africa and you're a clinician, you can become a member of SASHA and earn CPD points from these events. If you are one of our international guests, did you know that you can become an individual member of WAS? Please look at the WAS website, we'll share it in the chat, and apply for individual membership. Any clinician can become an individual member of WAS. But if you have a local organization, we encourage you to be a member of your local organization, and for that organization, then to become a member of WAS. This year, we will be electing a new advisory committee for WAS. That means that 19 people from all over the world will have to represent all that is sexual rights, sexual needs, sexual medicine, sex therapy, sex education. And you can only be on this board if you are a member of a member organization. Individuals cannot stand for this. Your organization needs to put you forward to stand to be chosen onto the advisory committee of WAS. I've been on the advisory committee for 8 years now, and it has been an absolute honor to be involved in sexual health on such a high level and to be given the opportunity to make a difference in many ways. So please, if your organization is not a member of WAS yet, please apply for membership so that you can be nominated to stand for the advisory committee of WAS. And then just on behalf of Pedro Nobre, who is the president of WAS, and of UMSCET, who is the honorary president of the upcoming WAS Congress, and Alan Jihami, who is the chair of the scientific committee, I would like to invite you to come to the Congress from 9 to 12 September. We've got the most exciting events planned for you. On 11 and 12 September, there will be live plenaries and symposia that you can log on to. We are using a phenomenal world-class conference platform with lots of interaction opportunities. If you are interested in sponsoring some events, please be in touch with us for our sponsorship prospectus, and then look out for our satellite events. We've got a sexual medicine workshop. We have a SAR, a sexual attitude reassessment workshop. We have a whole trans day happening on the 9th. We've got a free sexual justice in Durban, as well as a free youth congress connected to this upcoming congress. So please look out for the call for abstracts that will go out within the next few days. Check out the website, was2021.org, and we can't wait to welcome you to this congress. I'll just say this last thing. If you sign up now, it will only cost you like $70 for this congress, where you will have 100 lectures on sexual health, sexual rights, education, ethics. So it will be about $100 for 100 lectures if you sign up later. It is super affordable. You cannot afford to miss out on that. I am really looking forward to hosting you for the 25th Congress of the World Association for Sexual Health. Then lastly, our next webinar will be on the 9th of June, and it is on comprehensive sexuality education. Don't miss out on that one. Thank you again for spending this time with us. We appreciate your presence. Goodbye.